Excellent. Alrighty, everyone. Well, we're going to go ahead and get started. My name is Morgan Gargiulo from the New England QIN-QIO, and I'll be getting us started for today. Thank you for joining us for part 2 of this webinar on immunization. I'd like to go over a few housekeeping items before we get going. The call will be recorded for training purposes, and we will provide you with details on accessing the recording at the end of the presentation. The phone lines are on mute for the duration of the presentation. We will be taking questions at the end, and we'll let you know how to unmute your line at that time. During the presentation, though, if you have a question and you don't want to forget it, you can enter it into the chat box on the bottom right of your screen, but make sure to send the message to all participants so that we can keep up with all the incoming questions. If you find that the presentation's a little cut off, you can use the plus or minus icons at the top of the presentation to adjust accordingly. So with all of that said, I would like to pass it over to Russ to get us started.
Okay, thank you. Thank you everyone for joining us and for being part of the New England Nursing Home Collaborative, and for joining us today for part 2 of Chart from the Heart, which is meant to highlight everyone's role in protecting residents by ensuring immunization. I'm Russ Cooney and will be your facilitator. During this session, you will hear from one nursing home about how they were able to improve their immunization program, answer immunization questions raised during the first presentation as well as those identified in the post-event survey. We'll provide you information on the ACIP recommendations on Zoster Vaccination, and we'll discuss the immunization tracking tool, answer any remaining questions, and solicit any feedback. We'll also release the tracking tool during the event and pilot its use at facilities that are interested. The pilot will run from October 1st through March 31st, the flu season. Okay, next, let me introduce our first presenter. His name is Michael Patno, and he is the Regional Director of Clinical Reimbursement at Rowan Court Health and Rehab in New Vermont. Michael, welcome, and we'd love to hear what your story is. Thank you.
Very good. Can you hear me?
Yes.
Okay, just wanted to make sure I was that I was unmuted at the time. Well, first of all, thank you very much for having me on. I genuinely appreciate that. My name is Michael, and I'm an RN, Clinical Reimbursement Coordinator. Just a brief history, I'm currently at Rowan Court Health and Rehab. We're located in Barre, Vermont. It's a 96-bed facility and pretty much average long-term care, subacute rehab. I've done a little bit of everything, consulting, training, and currently I'm overseeing their Medicare and Medicaid at MDS at Rowan. So a little bit about Rowan Court. They were a special focus facility for the state of Vermont when I arrived. They had a 1-star rating. They underwent a number of major changes in their leadership. They have a new administrator, a new director of nurses, staff development. Nurses new. We have new unit managers on the wings and new faces in the MDS department. They also underwent a change in ownership. We belong to Rivera Healthcare Systems, and that was sold to Genesis and the Priority Health Group, and we are now under Priority Health Group. So that led, of course, to multiple challenges, and I think a lot of the information got lost, slipped through some of the cracks over time. And one of our biggest issues was our vaccination challenge for us. I'm on the vaccination challenge slide. Basically what we found out was that on the MDS, O0250A and or O0300A was being coded as not assessed. So we really weren't gathering the information that we needed to adequately determine the vaccination rates and levels of our residents. Led to a very low rate of vaccination on our quality measures. So we did know that it was going to require a good team effort to improve that. We needed to gather information, obtain orders, administer the vaccines when appropriate. But everybody came together on that pretty well. Next slide. Some of our solutions we did a 120-day look back on the MDS, and we're going to report for those two sections that were not assessed and that used a dash mark. That allowed us to focus on the residents that we needed to. In Vermont, we have the Vermont Immunization Registry. I gained access to that and reviewed all of the residents, first of all, there to determine if the flu or pneumovax had been given and was current. If that came up dry, we did go back and pull their hospital records. I had the admissions person do that. Then we contacted their primary care provider for confirmation. If we really couldn't find any information there, which wasn't common, we did offer the vaccination to the resident. We'll also say that we interviewed the resident and the resident's family as we needed to. We just obtained the order and gave it to the resident or family if they consented. And if the resident was not in-house at the time, particularly our Medicare people, we went again through the Vermont Immunization Registry and the primary care provider. At that point, once everything was completed, if they had the vaccination and it had been coded inappropriately on the MDS, we did go back and we did a modification and resubmitted that to Medicare so that the correct information was available. So following up and moving forward, our admissions coordinator is now very keen on accessing all of the hospital records for any of the vaccination information that might be available. We do interviews with residents and families on admission. We still access the Vermont Immunization Registry, and I would encourage anybody that's in Vermont to gain access to that. It is a most invaluable tool. And we continue with our questioning of the primary health providers. And of course, we offer the vaccines as needed here. But we do that on every admission and have done it going forward. So we have the systems in place, and we're capturing that information now. The basic results of that in the first quarter of 2015, our immunization for the flu vaccine was at 88.4%, and our pneumonia immunization rate was at 73.6%. And currently, our flu vax rate is 96.3%, and our pneumonia is at 98.4%, which is a fairly significant increase. And we expect that increase to be maintained or even improved going forward. So I just want to say that anybody who's an MDS or if you have an MDS coordinator, they're really key in monitoring your quality measures. I can just encourage you to print from CMS your quality measures and review them as a team, which we do here now at Rowan. And develop as a team, again, action plans to address any areas of concern. And I just want to say that it's worked out very well and we've been successful here. Thank you.
Thank you, Michael. That was great. Sounds like you've had a lot of success there. I'd like to open up the call for questions from the group. Morgan, can you please tell participants how to ask a question?
Yeah, if you have a question, if you could just press #6 on your phone to unmute your line, and then also make sure you didn't manually mute your phone as well. Again, it's #6. Or you can enter a question in chat. There currently aren't any questions in chat.
So Michael, tell me, was there a specific tool that you used when tracking your results?
When we were going through and to determine exactly which residents were not assessed, I just simply printed out. We use point-click care, and they have a report in there that allows me to access the particular area on the MDS that we wanted to. I just ran a comprehensive list of all residents who had not been assessed as far as receiving the vaccinations, and worked off of that list, basically. Any program that you have that you're currently using should be able to run the same.
Okay. And
I didn't have a special tool.
Okay. Do you also track your staff immunizations, and how did that go?
I'm sorry, staff immunizations?
Yeah.
Yes, they do track staff immunizations. I don't have that tool right here in front of me. I couldn't tell you offhand what the vaccination rate, but I know it's into the high 90s.
That's great. That's really good.
For staff.
Mm-hmm.
I think most people are acutely aware, even if not for themselves, but you're protecting the residents. And we have to do that.
Okay, Michael, we have a question in chat. How does the vaccine information statement get shared with residents or families at your facility?
How does the vaccine information?
Yeah.
Okay, so when a resident comes in, if we are unable to, I hope this is going to answer the question. When a resident is admitted, particularly if they're Medicare or Medicaid, we will access, first of all, their hospital records, which will give us the date that the vaccination was given. If not there, we access the Vermont Immunization Registry, and then I will go and talk with the resident or the family myself to see if they have had that. And even when they tell me, yes, we have, we still follow up. And when I say we, I mean the unit managers, the nurses on the floor will call the physician to confirm that they've had that vaccination. And then we go through the process of offering the vaccination to the resident and the family as needed if they require that.
Okay. Stefan, you had a question? Okay, Michael, I think what Dr. Gravenstein wanted to ask is the sharing of the vaccine immunization statement documented in your records?
Sharing of the vaccine statement. I guess I'm not sure of the question. The sharing of the vaccine. Well, we document if the resident has been given the vaccine in our MAR, in the medication administration record. There's also a nursing note that documents that, and I have the ability to enter in information into the Vermont Immunization Registry as required, so that it'll come up on further review. I'm not sure if that answers the question though or not.
No, that's fine. It's just we're trying to see what nursing homes are actually tracking, whether there is documentation that the person actually got the information statement.
But the information statement.
Yeah, the VISs.
They do, and I would have to ask Melissa. She's our control nurse. Where she's at.
Okay, no problem. I'll check with you on that later. Okay, Morgan, are there any other questions?
I don't see any others in chat. Again, it's #6 to unmute your line and ask a question.
Gus? This is Gail in Vermont, the QIO person, and the VIS statement has been a challenge in our state in terms of needing to send out to family members, particularly if the resident is not able to speak for themselves or give consent. The nursing homes are sending out annual consent with the attached VIS statement in there, so that when the family signs, they're actually signing for an informed consent. And I just had a conversation with our state surveyors about necessity of that based on our first immunization conference where I sort of heard that it might be okay just to post them throughout the facility and then to get a consent on admission. And Suzanne, our director, of survey said that they follow the CMS guidelines for obtaining informed consent. And she was pretty vague about that. So we need to do some follow-up because I do think that sometimes this very convoluted system of getting annual consents for the flu it slows down the whole process for us. Does that answer the question a little bit?
Yes. Dr. Gravenstein, would you have any comment on that?
No. Can you hear me?
Yes.
You can hear me? Good. I was having trouble getting unmuted before, so I'm going to disconnect my other line. So I think this is one of the topics we're covering later on. Right, so there's a requirement that the vaccine information statement be given out every time you administer a vaccine, whether that's to employees or residents. And I think, like the person from Vermont, I think there's a lot of issues with long-term care facilities trying to figure out how to get this done. And so I think the strategy is, if you haven't figured it out, try to develop a policy around how you do it. With the influenza vaccine, if you do a standing order at the time of admission to the facility and you hand it out at that time and recognize that this will happen annually, then I think you can do that vaccine information statement and potentially any others so that they get dealt with at the same time. So if you know, for example, you're going to be giving a pneumococcal vaccine or a Tdap or something like that, that you deal with them all together and you then plan on doing the vaccinations on whatever schedule you're going to do them on, but that it's understood at the time of their arrival. It's harder to do it on the fly, so every time if you try to do this every flu season, for example, with the flu vaccine, there's a fire drill that happens that you can avoid if you just get it taken care of at the time you write the initial order on their arrival. Usually there's family members or others around if the patient can't fully understand, so you can deal with it that way. So there should be you should have a log that it's been passed out also, so you can document that it's happened, and for each of the vaccines and who you sent it to. So if surveyors come in and look for this piece of information, you can just fill out a book and show them the log.
That's good advice on how to track those. Okay, so what we're going to do now is we're going to move on to address the questions from part one of our presentation. And Dr. Gravenstein, I'm glad you're on the line because I'm going to turn the ball over to you to cover the questions. But let me just review them quickly first. So the questions from the first event are, what immunizations should be given in the nursing home? How can we make influenza vaccines mandatory in our facility? If we have standing orders for flu vaccine, do we have to have signed acknowledgement of the vaccine information statement? How does influenza cause heart attacks? Where can I find educational materials to decrease infection rate? Should residents be given the shingles and DTaP vaccinations? And where can I find a list of other types of vaccines and their recommendations?
So quite a list.
It is, and just a reminder to participants, if you have other questions, please type them into the chat, and we'll answer them as time allows. And I'm now moving the ball to you, Stefan.
Can you put the questions back up again?
Sure. Actually, they go one by one, so we'll be putting those up in a second.
Okay. Looks like I get to advance the slide, huh?
There you go, yep.
Okay, so what immunizations should be given in nursing homes? So if ever you wonder about this, you can always go to the CDC website and look up vaccines and nursing homes, and you'll get to a page where it can show you a vaccine administration table. The big ones, there's one set for residents and a slightly different set for employees because they also have a risk of hepatitis. But in general, the one for residents should be specifically the respiratory pathogens, influenza and pneumococcal vaccines. And it's an opportunity to look and get them up to date in Tdap. If you do that just once, this is the tetanus, diphtheria, and acellular pertussis vaccine. That's a combination. If you don't have a date of when they were last vaccinated, then you should just pay them to give it, and that Tdap will last for their entire stay at the nursing home. So you can make this a goal of getting it done in the first month or two that they're there. For employees, there's also hepatitis vaccine. And then finally there's an additional vaccine that isn't required but is recommended, and that's shingles vaccine. Shingles vaccine is interesting because the insurance plans don't necessarily cover it. They have Medicare Part D. I think it is covered, but some of the other insurances don't. So for the employment, they need to have their initial records for prior immunity. That's the MMR, so you need to get updated on these if they don't have adequate antibody. So let's go to the next slide. There's a comment in the chat also, getting annual consent for the flu vaccine slows down the process. I would say it's worse than that. Getting annual consent for the flu vaccine also reduces the number of people who get it. We are currently doing a national study where we have over 800 nursing homes enrolled, and I would say a substantial minority, but a substantial number, have an annual vaccine consent policy. And those facilities typically have a lower vaccination rate than those who have it as a standing order from the time of admission. So in an ideal world, what you do with the flu vaccine, since this comes up every year, is at the time they're admitted, you announce that you plan on giving a flu vaccine each year of the flu season with all the other residents as part of your standard of care. And at that time, you will hand out and document it that you handed out the vaccine information statement. So for employees, it's interesting. In Rhode Island, we had a large discussion about whether you could mandate employees getting the vaccine, and this finally made it up to the Department of Health, who then said that this should be a requirement for healthcare workers. And I think in several states and in many hospitals around the country, employee vaccination is mandatory. The pushback has typically come from nursing unions who think this is a affront on their rights as individuals. And the discussion has also been around what's the evidence that vaccinating employees even protects the residents, let alone, they can argue about the staff. To the people who do vaccine research like myself, that's a lot like asking for evidence of whether a parachute works. Do you have to do a randomized controlled trial for that? So the folks who mandate it feel strongly that the evidence is adequate, even if it's not the highest quality evidence, and that it makes common sense that individuals who are providing health care would not want to be putting their own patients at risk from getting diseases that they might transmit, because they can transmit even when they don't know that they're, because they may not even know that they have it. Because in the first days when you get diseases like the flu or influenza, you may have influenza and you could be shedding it and transmitting it without even knowing that you're sick. By having a vaccine, the risk of that goes down dramatically. So strategically, it's hard to implement a mandatory vaccine policy for employees who have been working for you for 10 or 20 years. On the other hand, the turnover in facilities is so high that you could make it a condition of future employment. So when you hire new people in, that they recognize a condition of employment is that they do the things they can to provide the best service to their residents, and that includes protecting their residents from themselves and the risk of transmitting flu by getting the annual vaccine for influenza. Likewise, if your employee is over the age of 60, they should get the pneumococcal vaccine. I don't know if you're aware of the pneumococcal data, but with the new 13-valent Prevnar, when that was introduced for children, there was a reduction not only in those strains of pneumococcal disease in children, but also in the adults around those children. So we actually had a dramatic reduction. And I think that is pretty good evidence of transmission of the pneumococcal strains, and that the vaccine can prevent that transmission. So in your employees over 60, they should be getting that too. And I would argue that should be a mandatory vaccine for those employees over 60. Because the staff turnover rate is high, it's 60% or more in many facilities, you'll quickly get to where all of the employees are under that mandatory clause. And the ones that don't get it, we talked at our last session about how to encourage them to get it. I don't like using shaming, but shaming is certainly one thing that can work. And we talked about like having a pin that you get to wear once you get the vaccine. I got shot for you was an example of this. So if we have standing orders for flu vaccine, do we have to have a signed acknowledgement of vaccine information statements? So that is, you should see that as a standard of care and figuring out how to get it done. You might have a different strategy in your own facilities to nuance how it's administered. You could do more than just giving it out at the time of your standing order. You could also have it available along with your other documentation for the facility that shows your star rating and your survey reports and other kinds of things, so that anybody who comes to the facility can see what these are, and then have it distributed, just put a flyer in each person's room at the time you actually do the distribution, so if there's questions from family coming in on the day or the few days after that, those statements are around and that they have been shared again. I don't think you have to, I might be wrong on this, but I don't believe that once you've given a vaccine information statement that applies to vaccines that are recurring, that you have to necessarily do it to the LARs every year, unless the VIS itself changes in some way, in which case the information will be new. The VISs are sort of standard language. It is useful if you do regular communications with the legally authorized representatives, that if you know you're going to be doing some sort of regular communication for PR or other reasons, that's an opportunity again to share VIS if you know, for example, that flu season is coming and you're going to be getting the vaccine out. So you can do it in a redundant way, but I think I would do it in a standard of care way and then use other opportunities to continue to inform residents and their families of what's happening in the facility, so it'll reduce questions. So making it available at the nurse station each year when the vaccine is given or mailing it are among the options.
Stefan, there's a question in chat about what is the LAR?
So LARs are legally authorized representatives, so this would be the healthcare power of attorney or guardian, and those are the folks that would be making healthcare decisions on behalf of the patient if they can't do it for themselves.
Thank you.
So how does influenza cause heart attacks? This is a hard thing to describe in a few sentences, but I'll try. I give lectures on this that take an hour. So the very short version of this is when we get things that increase inflammation, so that can be any kind of infection, a bladder infection, any kind of respiratory infection, pressure sore, things like that. In our blood, the ability to clot, the tendency to clot goes up. So if you think of infections increasing the propensity to clot, you can think about when you get the flu, your risk for clotting goes up. And if that clot happens in your, as a consequence of inflammation in one of your heart's blood vessels, we call that a heart attack. And if it's in a brain blood vessel, we call it a stroke. So it turns out that when you get a flu vaccine, if you get influenza despite getting the flu vaccine, the amount of inflammation you produce is much less. So if for some reason the vaccine fails to protect you completely, it may still protect you well enough that you have attenuated disease and you don't get inflammation, and you get a lower risk of having a heart attack or atrial fibrillation or stroke. We'll be presenting data in October that puts numbers to this reduced risk of heart attack or stroke following influenza vaccine at ID Week. I won't say anything more about it now, but there are a variety of published papers out there that make the case that, in fact, flu vaccine might be even better than aspirin in preventing heart attacks. So again, the short version of this, when you have an inflammatory disease like an infection, it increases your risk for having a heart attack because it increases how well your blood clots. And if you do things that prevent the inflammation that occurs with infection like flu, or prevent the infection altogether, we will have a reduced inflammation and reduced risk for clotting, and therefore reduced risk for stroke. So here is a slide that shows where you can find education materials to decrease infection rates. These materials are pretty good, and you can see some of them are specific to long-term care. And you can see also there's a specific link for vaccines and vaccination schedules in this list. The last bullet there is also specific infection prevention related material. And ASA is creating a slide set for the infection prevention control officers that are going to be required to be trained by your facilities. So that is additional information that will be out there in the next couple of months. So, should residents be given shingles and DTaP vaccination? So you should know that that's Tdap, not DTaP. DTaP is the abbreviation for diphtheria, tetanus, and acellular pertussis, but it's a larger dose of acellular pertussis. And DTaP is for children. So Tdap is the one that we give for our older adults, and that is the correct one to give, and it updates them for all three of those pathogens. And if you don't know when their last vaccination was, these are only have to be given once for the rest of their life once they get to be old enough to be in a nursing home. Technically, it's every 10 years, but very few residents of nursing homes survive more than 10 years. Shingles vaccine is also an important vaccine. The shingles vaccine reduces the risk of shingles by 40 or 50%. But it reduces the risk of post-traumatic neuralgia, which can be seen from disabling, by up to 70%. So we recommend that with the shingles vaccine, the risk for shingles goes up in frail old folks, especially in their last years of life. So it's a good chance if they haven't had the shingles vaccine to get it. There's a new shingles vaccine coming on the market in the next few years that is an adjuvanted shingles vaccine, but it's too soon to know about whether that actually outperforms the current shingles vaccine in our oldest populations. So recognize your insurance may or may not pay for these. I think it'll pay for the tetanus, but many of them don't pay for shingles, and that vaccine is expensive. I think it's a couple $100. So you should know that pressure sores increase the risk for tetanus in the U.S., and the majority of tetanus cases occur specifically in older adults that have pressure sores. So I know that the nursing homes on our call today will all have very low pressure sore rates, so maybe it's not such a big worry, but it's cheap, and I think it's worth doing. So where can I find a list of other types of vaccines and their recommendations? So here you can see the ACIP and other recommendations. And there's also specific to pneumococcal and adult vaccine schedules. The top one is the table of schedules. So here's the recommendation for the shingles vaccine specifically. It's currently recommended for individuals over the age of 60. The literature actually supports giving it as young as 50 in the 50-60-year-old age group. But the official recommendations for the 50 to 60-year-old group is for folks specifically at increased risk for getting disease. You should know that living in a nursing home identifies you as a high-risk person. So in a nursing home, your employees should be 60 and older, but your nursing home residents, you can justify giving the vaccine as young as 50 years old. There is what I would call a better take of vaccine in that slightly younger age group, the 50 to 59-year-old age group. Those individuals have better responses than the 60-year-old and older, and they also get to be revaccinated. So you might get better lifelong protection by giving it at a slightly younger age. I think there's flexibility in the recommendation, so how you do what you do in your facility, you can tailor both by resources and by insurance coverage. Okay, so questions in chat. Let me see if there's something else there. Any other questions for me?
Actually, there is one in chat, Stefan, from one of our participants. It says, this year's information from the Mass Department of Public Health is that even people with egg allergies should get the vaccine. What are your thoughts about that?
So that recommendation is not just from the Massachusetts Department of Health, that's now a CDC recommendation. As far as the CDC is concerned, egg allergy is no longer a contraindication to vaccine. There's some nuance in how you give the vaccine. So even if you get hives, you can still get the regular vaccine. It's only if you have anaphylaxis that you need to think about doing something different than the regular vaccine. There's a recombinant vaccine that isn't produced in eggs that's available, and that recombinant vaccine can be given to anybody where there's a fear of allergy without having to do anything else differently. You still just do the same things about watching them for the 15 minutes after the vaccine, which is easy because nursing home residents are in that setting as our employees if they're getting it there. But if there's a concern about the allergy reaction, aside from going to a vaccine that isn't grown in eggs, you can use the vaccines that are grown in eggs. The amount of egg content is so low that the likelihood of anaphylaxis is very small. They just have to be observed potentially even for 30 minutes before letting them go. Most of the reactions that are thought to be around eggs are minor reactions, and they don't create risk for life. In your facility, you should have the ability to treat them if they do have an allergic reaction. And so whether you have, your epinephrine and diphenhydramine around, the Spears drug, that's typically the medications we are most likely to use when an allergic reaction presents. But again, I tend, even when we have minor reactions, I tend not to give them anything for the reaction because they do just fine. Just be aware that you should observe them.
Okay, there's no more questions in chat. Morgan, are there any questions on the phone line?
If you have a question on the phone, it's #6 to unmute your line.
Okay, Stefan, can you please pass the ball back to Melissa Miranda?
Okay, wish me luck on that.
Just drag and drop it.
Melissa, there you go. Just drag and click.
Yep, that was it. Thank you.
Yep.
Okay. So, for those who are interested in the immunization tracking sheet, we refined the spreadsheet to allow for a printable form for those who prefer working from paper rather than on the computer. If you enter the names on the computer, they will populate on all the sheets. If you print and then use the sheets, you'll have to enter the names on each of the sheets. As you can see, we've added columns for standing order, lot number, and injection site location. Hopefully this will help reduce the number of times that you actually have to go into the resident's record. The form will continue to auto-calculate any of your rates and create graphs for each immunization. If you'd like your graphs to include state and national rates, they can be found on Nursing Home Compare. And I know Nursing Home Compare breaks them down by long-term and short-term stay. But if you combine the two and figure the average from there, you can enter that. I did enter the national average on the one that will be sent out to anyone who wants to participate. If you decide that you want to pilot this, the pilot is again going to run from October 1st through March 31st, so the flu season. And when you receive the form, please allow macros. If you run into a problem with downloading the form, you want to make sure to give me a call, and we can see about downloading it from our website. Does anyone have any questions about the immunization tracking form, or any other questions for Michael or Dr. Gravenstein? Stefan, that's actually a great idea. In our chat, Dr. Gravenstein had said we could add a box to this form for what the VIS distributed to the resident, or LAR, and made available. So I think that's a great idea. So anyone who wants to participate in the immunization tracking pilot, all you need to do is type in your information into the chat, or send me an email, or give me a call. My phone number is 401-529-3226. Or you can get me an email at rcooney@healthcentricadvisors.org.
Let's work on that form.
are you there? Yep, we're here.
Okay, sorry
There's
about
a
that.
question on what do we do in order to be part of the pilot?
Okay, so the information is up on the slide now with my contact information. Again, it will run from October 1st through March 31st. And we want to make sure that people track at least influenza and pneumococcal. Any feedback or any technical assistance you need, we'll provide as needed. And we made it very simple. So on the first page of the spreadsheet is all the directions on how to use the spreadsheet. Okay, so we have a question in the chat. Nursing homes compare will report a home's data on flu vaccination. Can you elaborate how this will work? Yeah, so what happens is it reports it on flu and pneumococcal. So what I've done is I've taken for the national rate, I've taken the flu short-term and flu long-term resident, combine the two, and then just divided it by 2 to get the overall average. And you can do the same thing when it comes to the pneumococcal. Okay, if there's no more questions, we're going to wrap up. Thank you all for some really good questions. I have a few last announcements before we end today's webinar. First, I want to thank both of our presenters. They did a wonderful job. I really appreciate your time and effort. When you close out of this webinar, a brief survey will automatically pop up. We ask that you please complete it. It's very important because your feedback can help us improve our sessions and provide you with meaningful programs. If you're unable to complete the survey, at this time, a link to the survey will be included in the follow-up email, which will also include email links to today's presentation and a recording of the webinar. For those of you who choose to pilot the new immunization spreadsheet, it will be sent out to you immediately after the presentation. If you have any problem receiving it, again, give me a call and I'll help you download it from our website. Please join us for our next event on November 10th at 11 a.m. titled Shoot for the Stars, the New Quality Measures Affecting Your 5-Star Rating, with presenter Danielle Watford. Thank you again for attending and have a great day.
Thank you, Ross.
The leader has disconnected. The conference will be terminated in 5 minutes.